Hi, this is Keith. This presentation goes along with Chapter 12. So if you haven't read that chapter yet, it's a good idea to do that first and then watch this presentation. Please also note that this lecture is meant to support the material in Chapter 12 from the book. There's a lot more detail in Chapter 12, so be sure to read it. In this presentation, we'll discuss fertilization and fetal development, and pregnancy, infertility, giving birth, and postpartum. Let's get started. In this presentation, we're going to take a look at pregnancy and childbirth through the lens of biology, sociology, and psychology. Let's begin at the beginning, fertilization and fetal development. In an earlier presentation, we talked about female anatomy. So let's take a deeper dive into how fertilization and fetal development occurs. Once the oocyte, in other words, the ovum or unfertilized egg, is released from the ovary, it drifts into the fallopian tube, where it may be fertilized if live sperm are present. If the pregnancy proceeds without interruption, the birth will occur in approximately 266 days. Healthcare professionals count the first day of pregnancy as the date on which the woman began her last menstrual period and then calculate the due date to be 180 days. The oocyte remains viable for 12 to 24 hours after ovulation, while most sperm are viable for 12 to 48 hours in the female reproductive tract. But some sperm may remain viable for up to 5 days. So for fertilization to occur, intercourse must take place within 5 days before and 1 day after ovulation. However, even if a sperm reaches the oocyte quickly, it must wait a few hours before it can actually enter the egg, since it is not capable of getting through the outer layers. The process by which this occurs is called capacitation. Capacitation is a process by which the sperm's membranes become fragile enough to release necessary enzymes from their acrosomes, which is the helmet-like covering of the sperm's nuclei. The membrane of the sperm cell contains a chemical that helps adhere and eventually penetrate the egg's outer layer. Then once a single sperm is inside the oocyte cytoplasm, a chemical reaction occurs that blocks any other sperm from entering. Next, the oocyte becomes a mature ovum by forming the ovum nucleus. The ovum and the sperm release their chromosomes, which combine to form the diploid zygote, which contains 23 pairs of chromosomes. In this process, each parent contributes one chromosome to each pair, and now fertilization is complete. Once fertilization is complete, the zygote undergoes a series of cell division. After about 4 or 5 days, there are about 100 cells, which collectively are called a blastocyte. Around the fifth day, the blastocyte finally arrives at the uterine cavity and kind of floats around for a couple days before it implants into the uterine lining, which is also known as the endometrium. The full process of implantation takes about 1 week. The blastocyte, or preembryo, rapidly grows into an embryo, which will in turn be referred to as a fetus after the 8th week of pregnancy. Okay, in this figure, you see the progress of the released oocyte, in other words, the unfertilized egg, through fertilization and pre-embryonic development. The oocyte from the ruptured ovarian follicle moves into the fallopian tube, where fertilization by a sperm cell takes place. 24 to 30 hours after fertilization, male and female genetic material combines to form the zygote, which continues to move along the oviduct to the fallopian tube. In about 36 hours, the cell has divided into two cells, in 48 hours, 4 cells, and in 3 days, 16 to 32 cells. In the fourth day, it has become a hollow ball of 64 to 128 cells, and this is called a blastocyte, which arrives in the uterine cavity and floats around, like I mentioned before, for a couple days. At 6 to 7 days, a blastocyte attaches to the uterine wall, and at 11 or 12 days, the embryo implants into the uterine lining. During the first 2 or 3 weeks of development, the embryonic membranes are formed. This includes the amniotic sac, which holds the embryo and later the fetus. The amniotic sac has two membranes. the amnion, or inner membrane, which holds the amniotic fluid and the fetus, and the chorion, or outer membrane, which encloses the embryo and contributes to development of the placenta. The growth of the fetus is possible through the placenta, which is an organ that connects the developing fetus to the uterine wall to provide nutrients and oxygen via the mother's bloodstream. The placenta also removes waste products from the fetus's blood. The placenta grows larger as the fetus grows. The placenta is attached to the wall of the uterus and to the fetus's umbilical cord, which connects the placenta and the fetus. The placenta serves as a biochemical barrier between anything that enters the person's body and the fetus. However, there are certain prescriptions and other drugs, tobacco, alcohol, and some viruses like the Zika virus that do cross this barrier and can potentially harm the fetus. In this figure, you can see that the placenta is the organ of exchange between the mother and the fetus. The amniotic sac forms within the uterus. Outside the amniotic sac is a muscle layer of the uterine wall and the inner lining of the uterus, also known as the endometrium. The amniotic sac has an outer membrane called the chorion that encloses the embryo and later the fetus and contributes to the development of the placenta. The placenta attaches to the wall of the uterus and the fetus's umbilical cord, which connects the placenta and the fetus and through which nutrients pass. Maternal blood from maternal endometrial arterioles collects in the placenta and is distributed to the umbilical vein by the chorionic villi. In turn, waste products from the fetus's blood move through the umbilical artery to the chorionic villi in the placenta and into the maternal endometrial venule. As you can see, it's quite a complicated process. Okay, listed here are the different parts of the body that will begin to grow at different weeks. So, starting in about week 3, the development of the fetus occurs quickly, beginning with the brain. Around the 4th week, the heart begins to pump blood, and by the end of the 4th week, the spinal cord and nervous system have begun to develop. Around week 7, the reproductive organs begin to differentiate, as we talked about earlier in the semester. And by week 8, the fetus is about the size of a thumb, although most of that is taken up by the head. And many parts of the body, including the hands, fingers, legs, feet, toes, and eyes, are almost fully developed by week 12. By the 15th week, the fetus is covered with a fine downy hair called lanugo. Here you see the sizes of the developing embryo and fetus from the conception through the first 15 weeks. So let's walk through this. After the last menstrual period, ovulation occurs at 2 weeks. Implantation takes place in the 3rd week, and this corresponds to the 1st week in terms of fertilization age. The first missed period is in the 4th week after the last menstrual period. The second missed period and Hagar's sign takes place in the 8th week after the last menstrual period. We'll discuss Hagar's sign in just a bit. By 24 days after fertilization, the first body segments have begun to form and the embryo may be 3 millimeters wide. By 6.5 weeks, arms and legs have formed, the eyes and ears are forming, and the embryo is as much as a centimeter wide. In the 7th week, the reproductive organs begin to differentiate in males. As mentioned earlier, by 12 weeks, the arms, hands, fingers, legs, feet, toes, and eyes are almost fully developed, and by week 16, the fetus is several centimeters wide. Okay, so by 5 months, the fetus is about 10 to 12 inches long. At 7 months, it is 13 to 17 inches long, weighs about 3 pounds, and is likely viable at this point. By viable, we mean that the fetus is capable of surviving outside the womb. A full-term pregnancy lasts about 40 weeks. At full term, the fetus will be about 20 inches long and weigh about 7 pounds on average. Although 37 weeks is considered full term, even a few weeks early can mean greater risk of health problems. So, what are some of the ways that we can improve the likelihood of having a safe pregnancy and a healthy baby? The health of parents before conception and the woman in early pregnancy affects the health of the fetus. Preconception health is the health of individuals during their reproductive years to protect the health of a future baby. In contrast, prenatal care occurs after a woman becomes pregnant and involves monitoring the baby's development and the mother's health while she's pregnant. About three-quarters of females in the US obtain prenatal care within the first trimester, so that's the good news. But that still leaves a lot of room to engage people who are pregnant in prenatal care later on. Studies show that preconception health can be improved by physical activity, weight management, getting up to date on vaccines, avoiding smoking, drinking, and drugs. So preconception healthcare should focus on these behaviors and activities. All right, so backing up just a bit, let's briefly touch on how we detect pregnancy. There are a few ways. First, chemical tests can usually determine pregnancy about 1 week after a missed or spotty menstrual period. These are designed to detect the presence of human chorionic gonadotropin, or HCG, which is produced immediately after a fertilized egg attaches to the uterus. There are two types of chemical tests, a urine test and a blood test. The blood test can also determine a baby's sex at 7 to 20 weeks. Now, the second way is through what we call Hagar's sign, which is a softening of the uterus just above the cervix. This softening can be felt during a vaginal examination. Pregnancy can also be confirmed through the use of an ultrasound, which is a procedure that uses high-frequency sound waves to create real-time pictures or video of internal organs or other soft tissues. It can also be used to confirm that someone is pregnant. A woman's early response to pregnancy can vary dramatically. The pregnant person may experience feelings of ambivalence, and these feelings will probably change over the course of the pregnancy. The couple's relationship is also likely to undergo some changes. So, a pregnant person's relationship with their own mother may also undergo some changes. Again, whether these adjustments take place and the degree to which they take place can vary a lot from individual to individual. So, some people might experience ambivalence, some people may not, some people might have changes in their relationship with their partner, and other people may not. So, these are just sort of some general things that may happen. So here you see the principal tasks that expectant parents may experience as seen from sort of a heterosexual partner lens, where there's one female partner and one male partner. Now, some of these tasks may be different for same-sex parents or parents where one or both persons are gender diverse. With this in mind, for mothers, principal tasks may include the development of an emotional attachment to the fetus, differentiation of the self from the fetus, acceptance and resolution of the relationship with her own mother, resolution of dependency issues involving parents or a spouse or partner, and evaluation of practical and financial responsibilities. Now, for fathers, principal tasks may include acceptance of the pregnancy and attachment to the fetus, acceptance and resolution of the relationship with his own father, resolution of dependency issues involving parents or a spouse or partner, and of course, evaluation of practical and financial responsibilities. So you can see a lot of the principal tasks can overlap between the two partners. Studies generally show that the first trimester may be physically difficult for some people. Approximately 70 to 80% of women experience morning sickness that includes nausea and fatigue. In the second trimester, most nausea and fatigue disappear and the woman can feel the fetus move. And challenges may increase in the third trimester as the fetus grows. The mother may experience edema, pressure on the internal organs such as lungs and bladder, and overall may have less mobility. Again, these are possible changes that people who are pregnant may face, but certainly not everyone will experience these changes. So here you see a mother and a fetus in the third trimester of pregnancy. The expanded uterus affects the person's internal organs, causing feelings of pressure and possibly discomfort. Okay, so let's take a look at some of the complications that can occur during pregnancy that can be both dangerous to the person who is pregnant as well as the fetus. Again, these are potential complications that doesn't necessarily mean that any one person will have these complications at all. Teratogens are substances or other factors that cause defects in a developing embryo or fetus. So teratogens can come from many forms, but can include both things that the pregnant person ingests or environmental pollutants. The greatest vulnerability to teratogens is during the embryonic stage around 1 to 7 weeks and during early fetal development in the first trimester. Now, unfortunately, this may be the time when someone who is pregnant may not be aware that they are pregnant, and they may consume things like alcohol and tobacco during this period. Teratogens can cause birth defects, which are structural changes present at birth that can affect almost any part or parts of the baby's body. Now, a pregnant person's use of alcohol is probably the most studied teratogen. Fetal alcohol exposure may cause intellectual disability, and for this reason, there is no known safe amount of alcohol consumption for women during pregnancy or when trying to get pregnant. Now, unfortunately, research shows that about 3.3 million women each year expose the developing fetus to alcohol. There are a number of conditions that are the result of alcohol consumption, so let's run through a few of those. Fetal alcohol spectrum disorder, or FASD, is an umbrella term for a group of conditions with symptoms that include hyperactivity, poor language skills, concentration, and poor math skills. Now, one type of FASD is fetal alcohol syndrome, or FAS, which causes abnormal facial features, growth problems, and central nervous system problems. This is sort of the most extreme type of fetal alcohol spectrum disorder. Another type of FASD is alcohol-related neurodevelopment disorder, or ARND, where a child may show signs of intellectual, behavioral, and learning problems. And finally, alcohol-related birth defects also occur and may cause physical problems to the heart, kidneys, bones, or hearing. Besides alcohol, a number of other factors represent significant threats to the pregnancy and the fetus. Those include the following: chemical and environmental pollutants, tobacco use, which may cause low birth weight, smaller head circumference, a cleft palate, and lead to a higher risk for sudden infant death syndrome. Marijuana use, which can cause low birth weight and developmental problems. And then there are other drugs such as opiates, common prescriptions, and over-the-counter medications. So you should really check with your healthcare provider about those. Infectious diseases such as COVID-19 and Zika can be problematic. Sexually transmitted infections can also be passed on to the infant without proper precautions. And then things like maternal obesity. Now, becoming pregnant after the age of 35 is also a risk factor. So, this pregnancy after the age of 35 increases the risk of a child being born with a chromosomal abnormality. Now, this doesn't mean that a person giving birth after the age of 35 cannot have healthy babies. That can certainly happen. Rather, the risk for chromosomal abnormalities is higher, and options should be discussed with one's healthcare provider. Here you see the risk of having a baby born with Down syndrome by the age of the pregnant person. As you can tell, the risk is only 1 in 1,250 babies if the person becomes pregnant at age 25, and that increases to 1 in 100 babies for a pregnant parent who is 40 years old. So clearly the risk goes up. Another complication is an ectopic pregnancy, where the fertilized egg grows outside the uterus, which is usually in a fallopian tube. Now, the risk of an ectopic pregnancy may be increased by a previous ectopic pregnancy, or treatment with assisted reproductive technology, or growth of tissue outside the uterus, which is called endometriosis. Women of all ages may be at risk for an ectopic pregnancy. Another risk is gestational hypertension, also called pregnancy-induced hypertension. This is where a pregnant person has high blood pressure and edema, along with protein in the urine. This affects 3 to 5% of all pregnancies in the United States, and if untreated, it can progress to maternal convulsions and strokes. So it's important for all pregnant persons to have their blood pressure checked regularly. Another concern are preterm births, which are defined as births that take place prior to 37 weeks of gestation. Preterm births are common, impacting about 10% of all pregnancies in the US. Now, one consequence of preterm birth is low birth weight infants who weigh less than 5.5 pounds at birth. And while most preterm infants will grow normally, some infants will experience long-term neurological disability, such as feeding difficulties and cerebral palsy. About 35% of infant deaths in the United States are associated with preterm birth-related causes. So this really stresses the importance of prenatal care as a means of preventing prematurity. There are ways that we can detect and diagnose fetal abnormalities. There are prenatal tests, such as carrier screening tests, which can show if a person carries a gene for an inherited disorder such as cystic fibrosis. A cell-free DNA test is a non-invasive prenatal screening that utilizes some of the mother's blood to test for DNA. So this can be used to test for Down syndrome and other chromosomal abnormalities. There are also diagnostic tests to identify certain fetal abnormalities. For example, in chorionic villus sampling, a sample of cells is taken from the placenta. Another example is amniocentesis, where amniotic fluid is withdrawn and tested. A final example is neural tube defect screening, which is a blood test to measure the level of alpha fetoprotein in the pregnant parent. Okay, so in this picture, you see an example of amniocentesis and chorionic villus sampling. In amniocentesis on the left side, a needle is inserted through the abdomen to draw a small amount of amniotic fluid from the uterus. In chronic villus sampling, a catheter is inserted through the cervix to remove a small sample of cells from the placenta. Now, ultrasound is used throughout both procedures to monitor conditions. Okay, so let's turn our attention to pregnancy loss. The death of a fetus before 20 weeks is called early pregnancy loss, and this can be due to a variety of reasons. It can be due to a miscarriage or the spontaneous expulsion of the fetus. A death of a baby before or during delivery may occur, which is referred to as a stillbirth. However, loss may occur soon after birth. The infant mortality rate is the number of deaths of infants before their first birthday, often used as a measure of a nation's well-being. The estimated infant mortality rate in the US is 5.5 deaths for every 1,000 live births. Now, this infant mortality rate is far higher than in most other resource-rich countries. Sometimes an infant of less than 1 year dies of an unexplained cause, which is referred to as sudden infant death syndrome, or SIDS. One reason that SIDS may occur is due to unsafe sleep practices. So it is highly recommended that infants be placed on their backs to sleep and that their heads are not covered or overbundled by clothing or blankets. Of course, parents who experience the death of a child before, during, or after childbirth have feelings of shock and grief. It may be difficult for others around them to understand this grief, and therefore getting support from others who have experienced this may be important for the healing process. Infertility or impaired fecundity is the failure to establish a pregnancy after 12 months of regular condomless sex. By condomless sex, sometimes we refer to that also as unprotected sex. If the woman is 35 years of age or older, then it is the failure to establish a pregnancy after 6 months of regular condomless sex. Infertility is equally likely to occur in both men and women, with the most common risk factors being advanced age, overweight or obesity, excessive alcohol use, smoking, and excessive stress. Fertility problems can cause an emotional crisis for many couples. So coming to a joint decision about goals, acceptable therapies, and an endpoint for therapy is really important. So in the next few slides, we'll take a look at infertility issues for both females and males. Related to female infertility, about 10% of US women ages 15 to 44 have difficulty getting pregnant or carrying a pregnancy to term. While age is the best predictor of infertility, other factors can also be related to it. And those other factors include smoking, excessive alcohol use, poor diet, excessive athletic training, stress, being overweight or underweight, STIs, and health problems that cause hormonal changes. In this table, you see the percentage of women ages 15 to 44 years who experience infertility by age group. Overall, you can see that as females age, the percentage of them who experience infertility increases. For example, from 2015 to 2019, the overall infertility rate was 13.8%, but it really varied dramatically by age. So for persons aged 15 to 29 years of age, the infertility rate was 9.2. This increased to 22.2 for women who were between 30 and 39 years of age, and to 33.4 for women who were 40 to 49 years old, as well as for women who are older than that. But infertility is not just an issue for females, it's also an issue for males. About one third of infertility cases are cases where the male is the person who is not fertile. Infertility among males can be caused by a number of factors. Sperm can be altered by overall health and lifestyle. For example, having a varicose vein on the testicle, low sperm count, decreased sperm motility, and poor sperm morphology, in other words, misshapen sperm, can interfere with fertility. Other factors include age, alcohol, tobacco, drug use, and STIs. Also, health problems such as mumps, kidney disease, hormone problems, and certain medications and treatments can impact male fertility. So, what can be done about infertility? There are a few options. But before we get into those, while fertility problems are almost always physical, their treatment can be emotionally and financially quite costly. So, prior to medical interventions, typical healthcare providers might recommend lifestyle changes. So, one important way we might improve this is the timing of sexual activity to align with the female's menstrual cycle. Another important way may be for men or males in the relationship to change from a tight fitting boxer to a more looser underwear to decrease the temperature of the testes. Other changes might be to reduce alcohol, tobacco, and drug use, increase exercising, and eat a healthy diet. So those are the sort of the first line sort of behavioral sort of interventions that a healthcare provider might recommend. Now, if behavioral and lifestyle changes don't work, then medical interventions might be necessary. Techniques and technologies to promote conception include fertility medications, egg freezing, and surgery to correct a structural problem in either the male or the female. In addition, intrauterine insemination, also called artificial insemination, may be used to introduce the sperm into the uterus if the male sperm count is low. There are also assisted reproductive technologies which encompass treatments in which both egg and sperm are handled. So there are a couple of those. This includes IVF or in vitro fertilization, where the eggs are fertilized in the laboratory. It also includes intracytoplasmic sperm injection, in which a single sperm is injected into a mature egg. This process is usually done when there is a problem with the male's fertility. However, assisted reproductive technology is associated with high rates of multiple births, so there might be other options. So those other options include seeking another female to carry the fetus to term. And there are several options around this. The first is surrogate motherhood, where a surrogate mother becomes pregnant with the man's sperm and her own egg. In this case, the baby would be biologically related to the surrogate mother. Now, a second option is for the person to be a gestational carrier, where she carries the fertilized egg of the couple who wishes to have a baby. In this case, the baby is not biologically related to the gestational carrier. The success of these procedures relies on the age of the female. If the female is using her own eggs, there is more risk, especially after age 37, that the procedure will not be successful if she is older. The controversial development of assisted reproductive technologies is sex selection. And that allows couples to choose whether to have a boy or a girl. It's marketed under the title family balancing, quote unquote, but this really raises a lot of ethical questions that we really still haven't grappled with. Okay, so we talked a lot about issues related to pregnancy, but we haven't really talked about birth yet. Obviously, this is a topic we need to cover. During the later months of pregnancy, the placenta produces a hormone called relaxin, which increases flexibility in the ligaments and joints of the pelvic area. In the last trimester, the female begins to experience Braxton Hicks contractions, which are strong uterine contractions that exercise the uterus and prepare it for labor. Now, labor can generally be divided into three stages. True labor begins when the uterine contractions are regularly spaced. Effacement or thinning and dilation or gradual opening of the cervix occurs, and the fetus presents a part of itself into the vagina, usually within 2 to 24 hours. In the first stage, there is an expulsion of a mucus plug that has blocked the cervix. And at the end of stage one, there is a transition point when contractions come more quickly and are more intense. At this point, the cervix is now almost fully dilated at about 10 centimeters or 4 inches. This is when the baby's head enters the birth canal. Okay, so in the second stage, this is the time from when the baby's head moves into the birth canal and when the baby is born. When you hear the term crowning, this refers to when the baby's head emerges and does not slip back in. In stage two, the baby will still be attached to the umbilical cord connected to the mother. The cord should not be cut until it stops pulsating. The baby will also be covered in a waxy substance called vernix. Stage three comes after the baby is born. At this stage, the uterus continues to contract, expelling the placenta, the remaining section of the umbilical cord, and the fetal membranes. Attendants, usually physicians and nurses, but not always, will assess the condition of the neonate or newborn, rating heart rate, respiration, skin color, reflexes, and muscle tone using a system called an APGAR score. The mother will continue to feel contractions and will have a bloody discharge called lochia. Okay, let's review the process. In this figure, you see the birth process. In the first stage, the cervix begins to efface or thin out and dilate. In the transition stage, the cervix dilates from 8 to 10 centimeters. In the second stage, the infant is delivered. And in the third stage, the afterbirth or placenta is delivered. Now, there are choices that a person can make regarding childbirth. Most often, birth takes place in a hospital, which to some people can feel impersonal. So they may opt for a family-centered childbirth where partners and others can participate in the birth. Another choice is whether or not to have some pain relief during the process. And there are a few options. Analgesics provide pain relief, whereas anesthetics block all feelings. One form of anesthetic is an epidural, which is administered through a tiny catheter placed in the person's lower back. Another choice is whether or not to have an episiotomy. An episiotomy is an incision that enlarges a vaginal opening by cutting through the perineum. It's important to know that the American College of Obstetrics and Gynecology does not recommend the routine use of an episiotomy. So again, if at all possible, that Congress of Obstetrics and Gynecology says that you should not use that except in more rare or necessary cases. Another option is to induce labor with medications or other methods. Studies show that the best labor plan is to wait for the delivery to begin on its own rather than having an early birth through induced labor. Another option is to have a cesarean section or a C-section, where the delivery is through an incision in the mother's abdominal wall and uterus. A C-section may be the best option for many medical reasons that include abnormalities of the placenta and umbilical cord, or a prolonged or ineffective labor. And importantly, just because you've had a C-section in one birth, subsequent deliveries do not need to be C-sections. A program that has shown some success is what is called prepared childbirth, which was pioneered by gynecologist Grantley Dick Reed. Yes, that in fact is his real name. He recognized that if pregnant persons were anxious about giving birth, their muscles would tense and that would lead to more pain and discomfort during childbirth. So, through education and exercises, the pregnant person learns to relax during the process and experiences less pain and worry. And pregnant persons are increasingly choosing from among several alternatives to the hospital. Other options include birthing rooms and maternity centers, home births, and the use of midwives and doulas. Okay, so once a child is born, it's important to understand best practices for breastfeeding. Breast milk is the ideal food for babies. It contains the right amount of nutrients, boosts the baby's immune system, and is the best way to keep the baby healthy. Lactation, or the production of milk, begins about 3 days after childbirth. However, before lactation, a yellowish liquid called colostrum is secreted by the nipple to nourish the newborn before the baby's milk comes in. Colostrum is high in protein and antibodies that help protect the baby. All right, so to finish this presentation, let's consider the postpartum period, which encompasses the 3 months or so following childbirth. This is the time of physical stabilization and emotional adjustment. And you should know your rights as a new parent. The Family and Medical Leave Act assures eligible employees up to 12 months of unpaid, job protected leave for specific family and medical reasons with continuation of group health insurance. In this postpartum period, many mothers might experience sometimes what we call the baby blues, where they may experience irregular sleep patterns and feelings of isolation from their familiar world. A partner who did not give birth also has an important role. Their involvement in the children's lives have been shown to have a positive effect on the child's well-being, including later academic success and less involvement in delinquency and substance use. So importantly, both partners should be involved, not only obviously with the birth, but also after the birth. Now, about 10 to 20% of persons who give birth experience postpartum depression, which is a moderate to severe depression after birth. Postpartum depression is thought to be related to hormonal changes brought on by sleep deprivation, weaning, and the resumption of the menstrual cycle. Anxiety disorders may also arise or recur at this time. And a concerning problem that may happen is postpartum psychosis, where the person experiences many of the same symptoms of postpartum depression, but also may have delusions, hallucinations, or paranoia. Postpartum psychosis is thought to be exclusively biologically based and related to hormonal changes. Now, in the case of both postpartum depression and postpartum psychosis, professional help should be sought to address the symptoms. And that is the end of this lecture.